I have the real pleasure of sitting down right now with Dr. Eric Seaman.
Pleasure's mine, Sarah.
He is the urologist who focuses on male fertility at the New Jersey Urology.
It's actually a urology group of New Jersey.
Urology group of New Jersey.
And within that group, I specialize in male reproductive health, including male infertility.
Awesome. He's just a really incredible expert, giving a talk today at this conference on interesting and rare cases of male infertility.
Male fertility, that's right.
That's right.
Very big honor for me to be able to present to my peers who specialize in this on interesting cases that I've seen in male infertility through the years. So I'm looking forward to it. Well, hopefully you'll join me and
yes,
stop by.
I will definitely be there. I'm very intrigued to hear your research and your case studies of things that you've seen in your clinic, and very honored that you're taking some time out of your day to sit with us. So today I thought we could talk a little bit about vasectomy reversals.
Sure.
This is a big issue that we see a lot. Guys who have thought that they were done having children, and then now onto new relationships, or for other reasons now considering to undo what has been done. And
right.
So let's, I guess, to get started, there's about 50,000 of these, I guess, or more every year. Is that?
That sounds about right. Usually the patient wants to go see a doctor that does a fair number of these, because like anything in medicine or in any business, you do a lot of them, you tend to get better at them. And so there are a few of us sort of scattered across the country that do a good number. Now, as far as the people who do the reversal, kind of like you touched on, typically one of three categories. The most common setting is when someone's divorced and then they remarry. So they want to start a family with their new spouse. The second most common is a couple that thought that they made their decision and then they revisit their decision and they just change their mind. They want to have more children. And the third one is actually kind of sad. It's a couple that has a family and then unfortunately they lose a child and then they decide to reverse again. Although joyful if we're able to help them.
Wow, that's it's really just a real blessing, I think, for you to be able to see, new children coming after some of these situations, and being able to help men become fathers again, or sometimes maybe again.
It's nice. Not just the reversals, but even the whole male fertility practice. It's really a very special feeling when you can help people, and sometimes we get birth announcements. Of course, we can't help everybody, but for those people we can, it is very special.
Right. So let's start at the beginning of this journey. And if you're a guy, you've had a family, or you're just thinking about undoing this, it's a pretty daunting thing. You go in, this is a permanent, you've gotten a surgery to cut this off, and now you're thinking about reversing. What are some of the things you need to be thinking about and looking for in a doctor? Well,
as far as things you want to be thinking about, obviously the biggest decision is you want to have kids again. It's 2015, and so today we have options. It doesn't have to be a reversal, it could also be a retrieval. Some people decide they want to keep their vasectomy and maybe they just want one more child, so they'll have a surgical sperm retrieval and their wife will go through in vitro fertilization. That's the negative about the retrieval for some people, is it doesn't enable a natural conception. And for some people, they would prefer, if at all possible, to conceive naturally. But if that's not a stumbling block for them, then that works for people. But like you said, undoing the vasectomy is undoing the vasectomy and really reversing things, putting things back to the way they were before, or to the way fertility was before, hopefully. As far as the procedure itself, it's an outpatient procedure. It's considered minor surgery. Do you know the definition of minor surgery, Sarah? Surgery on somebody else. That's what most people think of. Minor surgery is always on somebody else. But on the scale of things, it's not as major as a hernia or as an appendix. It's an in and out, same day minor surgical procedure. For doctors that do a lot of them, I think pretty much all of us are doing it microsurgically. If a doctor says they use magnifying glasses or magnifying loupes, that's probably not somebody who is fellowship trained, somebody who has really taken the time to invest to do the most precise techniques of bringing the tubes together.
Okay.
And it can take a few hours to do. And then afterwards, the patient typically goes home with ice. And I'm going to just tell you what I tell my patients, but this is not necessarily what all urologists do. For my patients, I say they really have to ice it well for 24 hours, and they have to wear a support for 2 weeks. It doesn't have to be the same support, I tell them, but they have to wear some sort of support for 2 weeks. And I tell them no sports, no heavy lifting, and no sex for 2 weeks.
Okay.
And then I usually see them back at that time, and the idea is I examine them and hopefully give them the all clear that they can start resuming normal activities at that time.
Okay.
Now, it doesn't mean they have to stay out of work for 2 weeks. If they do heavy lifting for their work, then maybe it does.
Right.
But for most people, if they're doing something that's relatively sedentary, just not too physically active, they can get back to work in a few days.
Okay.
Vasectomy is typically accomplished in about 15 to 30 minutes.
Okay.
And it can be done in an office setting, or it could be with the patient asleep under an anesthesia setting. And so I get a little bit on my soapbox when I talk about patients who have vasectomy under anesthesia, because there's been a lot of bias for men to only have their vasectomy awake. But there are guys out there who are so anxious about the procedure, they wouldn't get it, but for the fact that they have that option of going to sleep for it.
Mm-hmm. So that makes sense. I mean, that's a kind of a terrifying thing, a little, you know.
Right. So I face this all the time where patients are so anxious and they come to see me and they say, oh, I'm so happy now I can go to sleep. And then the insurance company says, okay, but it's $1,000 deductible. And then they call my office back and they say, you know, I think I'd rather have it awake. And then I go to prepare the patient or put drapes on him or prep him, and as I'm doing it, the patient is literally moving away from me. Where are you going? Well,
Yeah.
I even had, you know, if the patient is so anxious for things medical that they faint every time that they have their blood drawn, it's probably not a great idea that they have their vasectomy when they're awake.
Right.
But we still see this sort of inducement by forces around us, not just insurance companies either, but even testimonials on the internet and physicians saying patients should only have it for awake. So there are patients that I think who are perfectly appropriate to go to sleep for vasectomy if they're very anxious about it. But if they go to sleep, it's still going to be about a 15-minute procedure, awake or asleep, the same technique, and they'll go home. In my practice, I'll tell them ice it for 24 hours, and then I usually say refrain from sports or heavy lifting for a week or two.
Mm-hmm.
So that's pretty similar to what my rules of vasectomy, with the only difference being that I say the patient for reversal.
Mm-hmm.
With the only difference being that for reversal, I want the patients to wear scrotal support for a couple of weeks because we want that reconnection to heal.
Right. Okay.
And then I say no sports, heavy lifting, or sex for 2 weeks. Whereas for my vasectomy patient, they could start returning to sex earlier than that.
But in vasectomy, you need to be careful because it's not empty, right? You have some.
So they can have sex, they just have to use protection.
Right.
And in my practice, my standard is they need to have 2 clean specimens, and I define clean as I don't see any sperm in 25 high-power fields on a microscope slide.
Okay.
They need to have 2 clean specimens by the time they hit 3 months after their procedure. So I usually look at one at 6 weeks, and I look at the second one at 3 months
Okay.
to hopefully get their 2 clean specimens. So for reversal, by the time the patients see me at their 2-week visit, they're usually mostly back to normal.
Okay.
It's not uncommon, though, that I'll see that there's some residual inflammation, and I'll just give them an anti-inflammatory like naproxen for a few weeks.
Okay.
And then I usually do my first semen test at 6 weeks.
Okay. Okay. So talking about scrotal support, what is that? Is that just tight
It's an
underwear
it's an
or
athletic supporter.
just wearing a regular athletic supporter? Okay. And ice, is it the same 24 hours or is it more or?
Yeah, a lot of patients say, and so that's 20 on, 20 off, doc? And I'm not sure where this concept of 20 on, 20 off came for what I do. I think it maybe came from dental care, because if you anesthetize the face and you leave ice on, you can get frostbite in your face. Not a good idea. So I think dentists say 20 on, 20 off. My father was a dentist, so I heard it growing up on the phone a lot. But, guys know when things are too cold down there. So I say, leave it on as much as you can stand. It gets too cold, take it off, and put it back on.
Okay.
And it doesn't have to be ice. It could be anything that keeps it cold. A lot of guys go on the internet and they research, go, I bought frozen peas, and there's a whole, and one of my patients after his vasectomy said, I got those frozen corn. And I said, you mean frozen peas? He said, no, I researched it. Corn holds more sugar, so it's a lower freezing point. I said, wow, you really made a whole science out of this. It's very impressive.
That's awesome.
Yeah.
Peas versus corn. They also make underwear now.
Yeah, with
that
ice packs.
With ice packs in them.
Some genius.
Yeah.
Why didn't I think of this?
So, okay. So when things get cold, the cremaster reacts and pulls the testicles up in. Is that okay? Is that cause any issues, or is that good?
That's true. That happens. The reason I'm putting the ice on is inflammation.
Okay.
So we really don't want a whole bunch of swelling going on around that reversal, and I don't want to give the patient an anti-inflammatory for the first 24 hours, just because the work I'm doing is micro work, and if there's a little bit of bleeding around that micro work, that also can cause some issues, and anti-inflammatory is in the blood. So I want that 24-hour period to go before the anti-inflammatory. So ice just to hold back the inflammation until they can get their anti-inflammatory.
Is it tender? Is there a lot of
There's
pain?
tenderness after vasectomy. There's tenderness after vasectomy reversal, and my experience is most people say it wasn't as bad as they thought it was going to be.
Okay.
And maybe a little bit more than the vasectomy, but not a lot more. But we're all types of people. So there are people who are more sensitive to it, and there are some people who are very, very tough.
Right. Okay. So we got 2 weeks of pause. Is the tenderness extend that full 2 weeks, or is it you start to feel better, you can start doing stuff, or do people start doing stuff early?
Again,
or
my rules for my patients is 2 weeks, no sports, heavy lifting, or sex. Period. So they may feel like they can do it, but I still don't want them doing it. I want them to let that reconnection heal.
Okay.
But people, it's the first couple of days, things are a lot more formidable than the last couple of days, that 2 weeks.
And okay, so you do your semen analysis at that 2 weeks, or
6 weeks.
6 weeks.
Yeah.
So you can start having sex at 2. Is that always 2, or
So
you're generally eager to get back to it?
I re-examine them at 2 weeks, and then I make my judgment. So
Okay.
sometimes I do call for an extra week if they still have a lot of swelling going on there, and I want them to get a full dose anti-inflammatory.
Okay.
But if it's not 2 weeks, usually it's 3 weeks.
Okay.
And so you may ask me how early is my earliest pregnancy after reversal? And I now have 2 patients in my practice where it was the first time they had sex after the reversal. Patient came in, I went out and said, your analysis looks really good. And he smiled, he goes, I know.
Attaboy.
And, well, why'd you have me do how come you have me do the semen analysis? If I just wanted to be sure, Doc. I said, but we're good. So that's happened a couple of times. And I don't know how they know it's the first time they had sex, but they both knew it was the first time they had sex after reversal. So that's not what always happens. That's more the exception to the rule, but it can happen.
Okay, so let's talk a little bit about that, the semen analysis. I know that sometimes you can have a higher white blood cell or round cell count in that first semen analysis. How common is that? Is that worrisome?
So I do semen analyses myself in my office, and the white blood cell or round cell count is 2 different things.
Okay.
So when you look at the sperm under the microscope, you'll see sperm,
Right.
and you'll see other stuff.
Right.
And sometimes you see these round cells. That's what they call round cells. And what are they? So you need to do a special test to see what they are. And we use a leucoscreen test to say, are those white blood cells or not white blood cells?
Okay.
So if they're not white blood cells, they're immature sperm cells.
Okay.
So anybody, in my experience, people who have a high sperm count, not uncommon that they also have some round cells mixed in there.
Okay.
I also see round cells commonly in patients who have varicoceles. Interesting, but this seems to be an association. White blood cells are different. So white blood cells are somehow mediating some sort of inflammation. And so now I'm going to circle back to your question about the round cells or white blood cells. Yeah, for my patients, I haven't noticed an increased incidence of white blood cells or round cells after reversal.
Okay, so you don't see that inflammation leads to.
No. What I do see sometimes is that the initial analysis, the sperm kind of hanging there, with some guys moving around them. And then
Okay.
we'll do another analysis, another 6 weeks, and then much better.
Okay.
So what's going on there? Well, right below that vasectomy, there's all these dead sperm.
Right.
Those got to come out first.
Right.
So
Okay.
sometimes at that initial analysis, you're seeing the laggards, that are sort of hanging out there, and then by the time we do it again, all those laggards are gone. They've already been flushed out of the system, and now you're seeing the true new sperm coming through.
So you really need to have quite a bit of sex early on to flush out the system, or many ejaculations.
I'm not sure. I know after vasectomy, you need to have 20 ejaculations before I want to look at that specimen.
Okay.
For after reversal, it's a good question. I don't know. It may just be something intrinsic to the person, how their plumbing works inside.
Right.
Maybe.
Okay, and so returning to conception rates, what's average, and how long do people, go, and when does it become concerning that maybe something didn't work, or you need to follow back up?
Right. So I usually go by what the semen analysis looks like.
Okay.
And the chance of my finding sperm in the ejaculate relates to the patient, and it relates to what type of reconnection I do. So if people go online, what they're going to see a lot of discussion about is vas to vas versus vas to epididymis. So there's a testicle, there's a testicle with sperm into the epididymis, which then connects to the convoluted vas, which is this curly structure, which then becomes the straight vas. So the straight vas is what we operate on for vasectomy, remove a small piece of it during vasectomy. So the first thing we do in reversal is we cut right below that vasectomy, and we look at fluid that comes out that testicular end of the vas. We'll take some of that fluid, put it in a microscope slide. What we want to see is sperm. Because if we see sperm, we pump our fist, we go, yes, we can do a vasovasostomy, a vas-to-vas reconnection. So why do we pump our fist and go, yes? Because we have a much higher chance of finding sperm in the ejaculate if we can do a vas-to-vas connection.
Okay.
So in my experience, it's 95% about to get sperm in the ejaculate after a vas-to-vas reconnection. I'm just going to finish. So if it's been a long time since the reversal, there can be back pressure building up along the testicular end of the vas into the epididymis, and one of those tubules in the epididymis can block itself off. If you blocked up in the epididymis, I connect your vas to vas, I didn't do you any favors because you blocked at the epididymis. We have to connect the vas above that epididymal blockage, a vas to epididymis connection.
Okay.
So just to give you an idea, I don't have a pen on me, but if you look at the ballpoint and the ballpoint pen, that's probably close to the lumen of the vas. It's really tiny.
Okay.
So if we're connecting into an epididymal tubule, those tubules could be 1/5 the size of the vas lumen. So it's a much
So you
more
have a bigger tube connecting to a smaller
it's a
tube.
much more difficult reconnection to do.
Okay.
And the success rates are lower. So in my series, it's about 60 or 65% of the time we get sperm into the ejaculate for vas to epididymis connections.
And you don't find that out until you're in there.
Correct. We don't
So
know. But
you
we
start
have
the
some-
procedure and you'll test and you'll look at the sperm and then you'll see what kind of thing you're going to be doing.
So if it's been a long time since the vasectomy, it's much more likely that you can do vas to epididymis than if it's been a short time. So we just had a lecture on this today. Once you get past 2 years after the vasectomy, we can't say whether we can do epididymis to vas or vas to vas. At 3 years after vasectomy, it's still much more likely vas to vas, and every year that goes thereafter, that vas to vas versus vas to epididymis ratio changes more and more vas to epididymis with every year that passes.
I see. And
So
what's kind of the end point where it's, is it
it's
10
maxed
years?
out.
Yeah.
So we hit somewhere between 10 and 20 years, sort of plateau that number, and at that time it's about 50-50.
Oh, 50-50. That's not too bad. That's not too
It's
bad.
not bad if you're in the good 50%.
Right, but still, I mean, it's
Yeah.
not 10%.
Correct. So then there's the additional factors of the patient. So remember, if it's 20 years since your vasectomy, you had your kids in your 20s, you're now in your 40s. So you're not as fertile as you were when you were in your 20s.
Right.
Most of us don't get younger as we grow up. Most of us get older with the passing of a year. So your sperm production and your fertility changes.
Okay.
So that's a second consideration as far as what we're going to see when we do the connection and how successful the connection is going to be.
Okay. There's a lot there, a lot to unpack. So let's start at the beginning, talking about retrieval versus reversal.
Mm-hmm.
And so you said, okay, if you get a reversal, or a retrieval, you're mostly going to be doing some kind of assisted reproduction. IVF, is it IVF exclusively, or is an IUI a possibility?
If it's a surgical sperm retrieval,
Mm-hmm.
which means that we're literally taking sperm out from the testicle or the epididymis, which are the tubes that receive the sperm from the testicle and hold on to that sperm, then you can only use those sperm for in vitro fertilization. Before there was in vitro, there were attempts to use these sperm with insemination, and the reported success rate was about 1%.
Ooh,
So
okay.
to do surgery and then have a 1% success rate probably doesn't make a lot of
Right,
sense.
okay. So really the negative to it is that you're going to have to do a medicated, true IVF.
Lots of IVF is done in this country, and people have become very good at doing in vitro fertilization, but that does become an extra burden for the wife.
Mm-hmm.
It is medication for several weeks. It's a procedure, usually with some anesthetic medicine to retrieve the eggs, and then once the embryos have grown and ready for transfer, the embryo is ready for transfer, then that again is another procedure, not a major procedure.
Right.
Again, this is additional things the wife has to do.
Right, right. Okay, and in terms of cost of the two, what's the cost of a reversal versus a retrieval with IVF cycle?
See, I find this to be a very interesting question, and whenever we get to dollars, physicians are very often uncomfortable talking about it because nobody wants to get into a price war. So somebody says a dollar figure on the internet, and then all of a sudden people go, well, who's less and who's more? And sometimes you get what you pay for, so sometimes a lower price service is lower price for a reason, although I guess not all the time. So this actually came up in the session I went to today.
Okay.
What is the price of a reversal and what is the price of an IVF cycle? So again, I can only talk about the prices that I know. There may be other sources of information. But reversals around the country, from what I heard in today's talk, talking to different people who do reversals, probably range in the $7,000 to $14,000 range.
Okay.
Now, when I say that's the cost of the reversal, I don't mean that the surgeon gets that necessarily. That is the all-in cost, which means that's
Hospital.
anesthesia, that's the center, that's the surgeon, that's the materials used in the procedure, that's the all-in cost for the procedure. IVF cycles, and I cannot comment across the country, but I can say in New Jersey, where I practice, the least expensive is probably around $10,000. And when I say $10,000, again, that's
The all-inclusive,
medications, that's ICSI, because for all male factor, they do ICSI where they inject the sperm into the egg, which is an additional cost. So that's the very, very least expensive I've heard is $10,000, going to probably around $18,000 or so. And that's just for the IVF. And sometimes there are additional things that are done on top of the standard IVF, but for the usual typical IVF, that's where it ranges.
Okay. So kind of in the economic sense, it almost leans fairly often towards the reversal, except for in maybe specific circumstances where maybe IVF is already on the table because of a female partner's issues already or something like that.
You can spin the economics a lot of different ways.
Right,
So
okay.
I'm sure I have colleagues who are reproductive endocrinologists who do IVF who could take the economics and sort of put a different spin, the number of attempts, the success rate, and the number of children you can have with how many success rate, the number of embryos you can generate.
Right.
But if you're looking at the procedure, then matching those dollars seems to come out less expensive for the reversal.
Okay. So I'm back here with Dr. Seaman, and we're talking.
I think we're getting every fact possible about reversal and retrieval.
I love it. So we were talking a little bit about the prognosis of how successful a reversal can be, and you brought up a really interesting point of, sometimes as you get older, your fertility is starting to decline, and even if you have a great reversal, really beautifully done surgically, you still might not get sperm back. And it sounds like there are ways that you can be able to guess that this might happen. So there are other tests that you can do. So maybe you can start back there a little bit and tell me about that.
Right. So rehashing what you just said. If the vasectomy was 20 years ago, and you were in your 20s when you had your vasectomy, and now you want your reversal, that means you're not in your 20s, you're in your 40s.
Right.
So nobody grows younger, we all grow older. And when that happens, our fertility changes too. For women, there's a more abrupt cutoff in how our fertility is when we reach our late 30s and early 40s. For men, it can be more gradual. But when I say it's more gradual, the slope is still downwards, it's not upwards.
Okay, yeah.
So things can change, and different people practice different ways. So again, I'm only speaking about what I do for patients, but I'll examine the patient, I'll look at their medical history. Smoking to me is the worst prognosis. If they're a smoker, I encourage them to stop. I prescribe a lot of Chantix to patients in my office, among other things, to help them stop smoking. Other lifestyle changes. And then some blood tests.
Okay.
So there are standard hormone levels that we look at when we're evaluating for men for fertility. So I do that for my vasectomy reversal patients before I do the reversal. I look at LH, FSH, testosterone, estradiol, and the liver panel. And FSH, I had just mentioned to you, is one of the key hormones that we look at. Men have FSH, follicle stimulating hormone. Women have FSH. In women, it relates to the eggs in the ovary. In men, it relates to sperm production. So in a man, if the FSH creeps higher, that's essentially a recognition by the brain that the testicle is not doing as well as it was with respect to sperm production. So if I see a man who has an elevated FSH, that's a prognostic indicator about how well they're making their sperm. And I actually have history of one patient that had an elevated FSH, and I said to him, I could do a beautiful connection and a beautiful reversal, but just realize, even though my surgery is great, the ability of your testicle to generate that sperm may not be enough to put a lot of sperm through that connection. So this changes our prognosis.
Right.
So what I did for that patient, he said, go for it. So what I did for that patient is I did my reversal, which I thought was anatomically very beautiful, but at the same time we did a surgical sperm retrieval to mitigate our chances. And sure enough, after the reversal, even though I thought I did a great reconnection, we didn't see any sperm in the ejaculate, but he had that surgically retrieved sperm as a backup plan.
And how many sperm were you able to retrieve in that case?
Well, testicular sperm, we don't do a sperm count like you do with an ejaculate.
Okay.
You're basically just looking at the tissue and the quality of sperm. But I could see, when I do a retrieval, I look at the tissue, little droplet of the tissue. I want to give most of that tissue to the lab.
Right.
I'll just look at a small portion of it myself in the microscope of the operating room. And I could see that he had some very nice looking sperm morphologically, which means good shape,
Right.
adequate sperm with some motility.
Swimming and everything.
So we could send that specimen back to the lab
Okay.
for them to freeze and use later.
Okay.
And I actually have now gotten to the practice of offering that to all my vasectomy reversal patients, that as a backup plan, they may want to consider a surgical retrieval, hedge their bets. Because even in that chance where I say it's 95% chance we're going to get sperm in the ejaculate,
Right.
but if you want to hedge that 5%, then we can do a retrieval at the same time.
Right.
And I don't charge any extra for it. For me, it's one package whether I do it or not.
Nice.
It's an additional time that you're asleep to do the procedure, but I haven't negotiated that it's one fee whether we do it or not.
Gotcha. Okay, so this is something to bring up with your urologist if you are considering a reversal, that you might want to consider also doing a retrieval at the same time as a thing, and
Right.
your urologist should be able to do something with
Well,
you
it
to help
depends.
you.
Well,
How they do
again,
it.
I can't speak for other urologists. I can only speak for myself
Right.
in my practice. But that's what I recommend at this point in time.
Right.